Okay, good morning, everyone. My name is Melanie Luseno, and I will be your moderator for the session. I am a fifth-year medical student on break, and as my bio says, I love cooking and baking at the moment. Um, so first, I would like to introduce the platform XYZZ. It's a vibrant community of Kenyan medical students from various universities in Kenya. The initiative aims to create accessible, locally relevant, and context-specific resources that addresses the unique healthcare challenges faced in our region. Kenya's current medical education system heavily relies on foreign resources, which are often not entirely applicable to the local healthcare landscape. This mismatch results in gaps in both education and preparedness among healthcare professionals, while also contributing to a limited public awareness about various medical conditions, further complicating healthcare delivery in the country. To bridge these gaps, XYZZ Med is developing a variety of educational resources, including relatable medical illustrations, case simulations, lectures, quizzes, healthcare stories, research, and interactive learning tools. This continuous medical education series is one of our key initiatives aimed at promoting peer-to-peer learning among medical students. We recognize that it is often easier to understand complex medical concepts when explained by peers or classmates, and this is why we've designed this series. Today's CME will focus on intussusception. We're pleased to introduce our speaker, Samara Johnson, who will take us through this important topic and help us deepen our understanding on its clinical significance. Samara is a sixth-year medical student at the University of Nairobi, and she has a deep passion for mentorship. She loves to learn and is committed to sharing her knowledge and skills with others. Her hobbies include calligraphy and music. Welcome, Samara.
Thank you so much for that wonderful introduction. Hi, everyone. So I think we'll just get right into it. I'm going to share my screen, and you can let me know if you're able to see it. Just give me a minute. Sorry about that. Okay, I'm not sure. Are you guys able to see my screen?
Yes, we can see your screen.
Okay. So yes, we can begin. So today's topic is on intussusception. And this was a topic that I found hard to understand until I came to sixth year. So now that I've read a lot about it, I hope that I can also make it easy for all of you to understand. So yeah, let's just get into it. What are our objectives for today? We're going to look at just a quick introduction, look at the epidemiology, the classifications, presentation, the management, and we'll have like a small case discussion just to see a case and learn something specific from that case. So what is it? What is intussusception? So it comes from, I'm not sure if it's Latin or I don't know the language, but it comes from two words, intus, which means within, and the suscipa, I can't pronounce that, but it means to receive. So it just means something is going inside and something else is receiving it. So the definition is just the invagination or telescoping of proximal bowel into the distal bowel. All right. So you can see a couple of photos here, images. So this is from the outside. I don't know if you can see this blue circular thing. So I'm just gonna
we can see it.
Okay, perfect. So you can see there's this bowel on this left side, and then there's the one on the right. So the one that's going inside is the proximal bowel. It's entering into the distal bowel. So you can see it's like this is a cut section. So you're seeing from within. You can see how it has entered the distal bowel. This is another image just to show that. So you have two parts. You have the intussusceptum. So the intussusceptum is this proximal bowel that's going to enter the distal segment. And then you have the intussuscepiens, which is now the distal bowel which is receiving the proximal segment. So once again, this, like on this image, whatever is entering inside is called the intussusceptum, and whatever is receiving that, which is this one, is called the intussuscipiens. Okay, and then you have the apex. So the apex is just the most distal part of the intussusceptum, which is now inside the intussuscipiens. Okay, so this area over here is called the apex. So intussusception is one of the common causes of intestinal obstruction in infants and in toddlers. So I hope that definition has made sense. So we'll just go through epidemiology. So the age, normally it's between 3 months and 36 months, or 3 years. Some sources will tell you 2, some will say 3. You can go with either. And the peak presentations are normally between 6 to 9 months. So between 6 to 12 months, about 50 of these patients come when they're 6 to 12. 75% are below 2 years and 90% below 3 years. So majority of these cases present before 3 years. It's more common in males than females. So the ratio is 3 to 2. The ratio, the incidence is 5.1 to 4 cases in every 11,000 live births. So there's been a note of seasonal variation. So there are studies that show that there's an increase in cases in hot weather and cold weathers. And it has been seen in relation with GE, gastroenteritis, due to rotavirus, or respiratory infections due to adenovirus or any other cause. So yeah, that's on epidemiology. So we go to classification. So you can classify it according to the anatomical classification or the pathological classification. Okay, so we'll start with the anatomical. So the anatomical is now where in the colon is this intussusception happening. So the most common is the ileocecal or the ileocolic. Same thing. So what is the ileocolic or ileocecal? It's when the distal ileum is going to invaginate into the cecum through the ileocecal valve. All right, and the ileocecal valve in this case tends to be the apex. Remember, we said the apex is the most distal part of the intussusceptum, right? So the apex in this case would be the ileocecal valve because it enters into the cecum. So this is the most common one seen. Then you can have ileo-ileal, where the ileum just enters into the adjacent ileum. So it invaginates into the adjacent ileum. Can have colic. So that's now the colon invaginates into the adjacent colon. This one is normally secondary to a tumor. Then you can have ileocolic, where you have an ileo-ileal intussusception. So the ileum invaginates into the adjacent ileum. Then that now extends into the colon through the ileocecal valve. So that's an ileo-ileocolic. So in some very rare cases, you can have reverse or retrograde. So remember, we defined intussusception as proximal bowel invaginating into distal bowel. But now in some rare cases, you can actually have it go the other way around, where the distal bowel will invaginate into the proximal bowel. So that would be the reverse or retrograde. But just for a takeaway from the slide, ileocolic or ileocecal is the most common one seen. All right, so we now go to pathological classification. So in pathological, you have the non-pathological or pathological cause. So we'll start with non-pathological. This is when intussusception, the major cause is just idiopathic. No one really understands why it happens. It just happens with no underlying cause in 90% of the cases. So there is no specific lead point. We'll talk about what a lead point is in the pathological classification. So what the understanding or the theory is you have hypertrophied inflamed Peyer's patches that are throughout the intestines, right? So when they are inflamed and they become bigger, they'll protrude into the terminal ileum, and that will cause the ileum now to invaginate into the cecum. All right, so that's just the theory that people are working with, but majority of the time it's idiopathic. So some of the causes for this is during weaning. That's why a lot of the cases are when the child starts to wean. They're starting, semi-solids and all of that, and breastfeeding is slowly moving out. So 6 months and above. So the sorry, this is supposed to be alteration. So in weaning, you have alteration of the bacterial flora and causes enlargement of the pious patches. Sorry if the spelling mistakes, I'll correct that. You can also have infections. So if you have adenovirus or rotavirus, it can cause inflammation to the pious patches. So that inflammation will make the pious patches bigger, then into the terminal ileum, pushing the ileum into the cecum. So this infectious one is most common in the children, especially ileocolic. Okay, so this is just the theory, but a lot of the times these things are just idiopathic. So now what is the pathological class part of the classification? So now this is where the pathological lead points come in. Okay, so pathological lead point is just a condition in the intestine which will now cause an intussusception. So some of these examples are Merkel's diverticulum, which is the most common, can have tumors like intestinal lymphomas, polyps, hemangiomas, appendix, duplication cysts, or any other mesenteric cysts, heterotrophic pancreas, ascaris worms in the intestine. So you have these underlying pathologies which will now cause peristalsis of that proximal bowel to get into the distal bowel. Okay, so these are normally seen in children above 2 or 3 years and in adults. So if you can have intussusception in adults, although it's mainly seen in children. If you have an adult patient presenting with intussusception, there is going to be a pathological lead point. So you need to investigate and find out what is that underlying cause. So in adults, it's not idiopathic. There's something happening. So even in older children, always be suspecting of a lead point. But if they're below 2 years, you might not find these lead points, but it's good to investigate. So the incidents are, basically, if they're 1 year, less than 5% present with a lead point. If it's 5 to 15 years, 30 to 60 will present with a pathological lead point. So you need to investigate them more carefully. And in adults, all of them will have it. There's no one that really presents with an idiopathic intussusception. So clinical factors associated with the lead point. Normally, if you find a colocolic intussusception, there is most likely a lead point. We said tumors are the main cause seen in colocolic. It's more seen than now, even if you have an ileocolic, you can have a lead point, more common in colocolic. It's seen in older children. We talked about it, more than 2 or 3 years. If the patient is having chronic GI symptoms or weight loss, there's a possibility there's an underlying lead point. If there's a recurrent intussusception in 35% of the cases, you're going to have a pathological lead point. So you just keep this in mind as you're investigating the patient so you don't miss out on lead points. So we said that a lead point is basically something in the intestine, a pathology in the intestine causing increased paralysis, and then you'll have that peristalsis, and then the proximal bowel invaginates into the distal bowel. So you can even have predisposing or other risk factors. So bleeding disorders like Henoch-Schlogen, I can't pronounce, I'm so sorry. That purpura has been seen. Studies have shown that this is a risk factor for intussusception. Hemophilias, leukemias, trauma to the abdomen, or even any retroperitoneal or abdominal procedures can be a risk factor for intussusception. Patients with cystic fibrosis and celiac disease are also known to be at risk for intussusception. So these are just some predisposing factors that you can be thinking about. So we look at clinical presentation. So we have abdominal pain. So older children will be able to tell you that I'm feeling pain in my abdomen, those who are able to talk. But what about infants who can't talk and cannot say that I'm feeling pain? They'll be mostly irritable, they'll be crying a lot, maybe holding their stomach. Babies like this little child, not crying, but you see how this baby is holding their feet up. So you'll have episodes of crying and they try to hold their feet up because this tends to relieve that pain. So this is a classic finding in intussusception. So this is intermittent. So the pathophysiology behind the pain is there's increased peristalsis, especially when they're feeding and all of that. But remember that the bowel has invaginated, so there's kind of some obstruction because part of the bowel has narrowed. So maybe not complete, but there is some. So there'll be intermittent pain. Then as the intussusceptum goes further into the intussusceptions, it will go with the mesentery, right? And the mesentery has blood vessels which supply the bowel. So when you're going in with the blood vessels, you're kind of compressing them. You will have obstruction to those vessels. You'll have less blood flow to the bowel. Then with time, ischemia will develop, and that's when now they'll tend to have constant pain now. So initially they start with colicky pain or intermittent pain, and then it will, if it's now it's too late, then now that will be constant because of constant ischemia. So yeah, that's how they present: irritability, crying, intermittent crying. So they'll have like episodes of crying and then they'll be fine. They'll be completely fine in between. They'll also present with legs, holding their legs up like this. Then you'll have red currant jelly stools. So mom will tell you, I'm seeing the baby when they're passing stool in the diaper, it's red, there's blood, it looks like jelly. Okay, so the pathophysiology behind that is when you have ischemia to the bowel, you'll have surging of the mucosa, and you'll also expose the vessels. So you have the blood supply being affected, and then the mucosa will also secrete a lot of mucus. So it's blood and mucus combining together to form that jelly appearance. There's also venous congestion because of that mesentery going with the blood vessel, congesting the venous supply. You can have bleeding. If you have venous infarction, you can have mucosal ulcers, which will also cause bleeding. That's why they present with red currant jelly stools. Other clinical presentations involve either abdominal distension or abdominal swelling. This is mainly seen, especially the distension is now when they're going towards intestinal obstruction, fits of screaming, lethargy. They can have a rectal mass because you see the intussusceptum can really go through the entire colon and even come into the rectum. So they can present with a rectal mass. They can have bilious vomiting or even non-bilious vomiting. Usually a late feature, especially if it's bilious, you should start thinking that there is intestinal obstruction, total intestinal obstruction. You'll also have to check for now other risk factors. So think of if this patient has had a history of URTI recently or been treated for gastroenteritis or any other, the lead points that you're thinking about, ask for features of those lead points to rule them out or rule them in. So yes, so viral infections and all of that. So they'll present like that. So there's this classic triad that is seen in patients, but now it's not seen in all. So just because the triad is not present doesn't mean that you can rule out intussusception as a diagnosis. It's present in like 20 to 50% of the cases. So what is the triad? It's the progressively increasing intermittent colicky pain relieved by assuming the fetal position, pulling the legs up to the abdomen. We saw that. Then you have an abdominal mass, which is in the intussusceptum. So a lot of them are like a curved sausage-like shape, and it's usually in the periumbilical area, but you can have the mass in the left upper quadrant, you can have it in the right upper quadrant. It's not specific to the periumbilical area, but you will have an abdominal mass and then the red currant jelly stool. So this is the triad for intussusception. Okay, so what are our examination findings? General exam, generally sturdy. They're well developed, they're well nourished, especially if they've still not had complete obstruction, so food is still getting in. So maybe in the later stages, if they're not feeding well, then the nourishment will go down. They could be sick looking, they may be in fair general condition, lethargy, dehydration, especially even if they're not vomiting, but if they're vomiting or just generally there's poor absorption of things, so they could have dehydration, pallor, fevers, and tachycardia. Okay, that's basic, some general things you'll see in general exam. Systemic exam, you'll have a palpable abdominal mass. You can have the dance sign. So the dance sign, you can see this abdomen. You can see like over here, it's that sausage-like mass I was telling you about. So the dance sign is when you palpate this right iliac fossa, it's completely empty. But you will have a mass either on the right upper quadrant, you can have it in the periumbilical region, you can have it in the left upper quadrant, anywhere on this side. So your abdominal mass with the empty right iliac fossa. So you press, it's completely empty. The pathophysiology is when the intussusceptum enters in or invaginates and starts going up this colon, it kind of pulls upwards, so it empties up the space that's in the right iliac fossa. So you have the intestines, then you go to the cecum, ascending colon. So as it starts invaginating upwards, it's pulled towards this side, then it moves here, goes that way. So this area is empty of any bowel. You can even see visible peristalsis on the abdomen. The mom will tell you, even when you're examining, you can see that because it's slightly narrow, so the bowel is really trying to push food or everything through increased peristalsis. You can have a palpable or non-palpable. Maybe there might be a rectal mass if it has gone all the way to the rectum. There might not be. You can have red mucoid stool. So when you do a DRE, you'll find blood in your glove. Could be due to a prolapsed intussusception, so the mass is coming. Then you'll have tenderness. You can have tenderness and guarding. So intussusceptum can perforate. We look at the complications, it can perforate. So in that scenario, you can have peritonitis and they'll have tenderness and guarding. So you'll also look at signs and symptoms of shock because that's another complication. So I think we just look at the complications. So one, intestinal obstruction. So you need to, that classic triad, the classic four signs, cardinal signs of intestinal obstruction, you rule them in or rule them out. You can have dehydration. So you can see that in your examination. You can have necrosis or gangrene of the bowel because you see you're cutting off blood supply. So there'll be constant pain and all of those things. You can have perforation, which will lead to peritonitis or even sepsis. So you look at those signs and symptoms in the patient. You can have shock. Okay, so these are some of the complications of intussusception. So what are some of the differentials you can be thinking about? You can have dysenteric gastroenteritis. You can have mesenteric cysts, especially if you're having a mass. If you have a mass in the, or a swelling in the abdomen, you can think of things like a cyst, you can think of tumors and all of that. You can have volvulus as a differential, rectal prolapse, because the rectal mass, rectal stool can be seen in both intussusception and a rectal prolapse. In older children, they can actually present you might even think it's appendicitis. So you need to be really careful in making sure you rule it out. These are just a few, but there's so many out there that you can go and check out. But these are some common ones that I've seen around. Right. So how would we investigate this patient who has come to us? We are suspecting intussusception. We've examined and taken a good history. So we can divide our investigations into our labs and our imaging. So let's start with our labs. You'd want to do a full blood count. So you look at the HB count, sorry, not RBC, HB count, your WBCs, you want to rule out any infections, your HB, if they might be bleeding, especially if they're passing blood in stool, you want to just confirm the HB. You can even look at their MCV and all of that, just because sometimes in bleeding and all, you can have iron deficiency things or microcytic anemia. So you'll just look at all those parameters. You'd want to do a UEC. In dehydration, you can have kidney failure, or even just check the electrolytes, how they are, especially if they're vomiting. You'd also want to do a BGA. So in dehydration, what are the parameters you'd be expecting to see? Maybe the creatinine will be a little elevated, or the ureas. In a BGA, if it's a hypovolemic shock, they'll tend to have lactic acidosis, because remember, in our anaerobic states, when we don't have oxygen, we're producing lactate. So you'd have lactic acidosis. If there's a lot of vomiting, you could have metabolic alkalosis. You can look at the pathophysiology of why that is there. You also check their potassium, their sodium, bicarbonates, and just to make sure everything is okay, or you need to correct something. So this is the sum of the labs. If they're you can then now it's according to the patient. We're going to look at a case at the end, and we'll see how according to the patient you'll have some more labs that you might want to do. In terms of imaging, your first line of investigation is your ultrasound, abdominal ultrasound. You can do a abdominal x-ray, but it's not that helpful. A lot of the times you won't find a lot of things unless you're a really good radiologist and you're able to pick it up. So you can do the supine view or the lateral decubitus in children. You can do a contrast enema, which can be both diagnostic and therapeutic, and a CT scan. I'm really sorry for all the spelling mistakes that I hear. You can do a CT scan. But the gold standard, or the first line, is an abdominal ultrasound and even a contrast enema. Okay. So ultrasound findings. So there's this findings that tend to be classical for intussusception. First one is a target sign, or even called the donut sign. So you can see this there'll be a hypoechoic a band, and then inside there'll be hyperechoic. So hyper is the white parts, hypo is the dark parts, and then so it's alternating hypo, hyper, hypo. So it's a target because it kind of looks like a target. You know, if any of you have played darts, or even a donut, if anyone has eaten a donut, you'll know this is what it looks like. So alternating hypoechoic bands, that's seen in intussusception. You can also have a pseudo kidney sign. So I put this image because this one shows, this image here is a kidney, what the kidney looks like on an ultrasound. And this is an intussusception. So they look very alike, like especially if you don't have a kidney to compare really with it, and you don't know what you're looking at, you can actually mistake this for the kidney, but it's actually the intussuscepted bowel. So those are two of the signs that you see on ultrasound. You can also see dilated bowels and all of that. You can see, you might see edematous bowel also, but these are really classic signs for intussusception. Okay. On a CT also, you can be able to see, especially in adults, it's good because a CT, what it will help you with is it can also help you pick out pathological lead points. So just two views. This is an axial view right here. You can see this where the arrow is pointing is the intussuscepted bowel. On the coronal view right here, also you can see the intussuscepted bowel right here. So you can make a diagnosis with a CT scan. Try to avoid CT scans in children because you don't want to expose them to radiation. Now, when you do an enema, you will push contrast through the bowel from the rectum or the anal opening, the rectum. So it will pass through until you reach where the intussusception has occurred. So you'll see something called a claw sign or the meniscus sign. So you can see this right here. This is the claw sign or the meniscus sign. So this is where the proximal bowel is reached and it's invaginating. It's probably the apex of the intussusceptum. So you do not want to do a barium enema in patients with suspected gangrene. So you need to be very good in your history and your examination. If you suspect gangrene or even a perforation, you think there's a perforation, there might be peritonitis, do not do a contrast enema. You don't want to make those things worse. All right, so that's the contraindication for this investigation. So yeah, that's just a quick on investigations. Now we'll look at the management. So we divide our management into our supportive and our definitive. So in our supportive, if this baby has come to you, they're unstable or they're having shock, they're having signs of shock, the first thing you do your primary survey. So your ABCDs, hopefully all of you know what that is, but you'll make sure their airway is okay, breathing is fine, circulation is okay, disability and exposed. So you have to stabilize them before you do anything else. So this baby is stable, they're okay, look fine. You want to put some tubes in, so you'll decompress with an NG tube and you'll keep this baby NPO until you have decided what your definitive management is. Then since you're keeping them NPO, you'd want to do your IV fluids, rehydrate them, because we've talked about dehydration. So give them IV fluids, rehydrate them, and put a urinary catheter to monitor output so that you're not giving them excess fluids. Then you can observe their vitals, so a frequent clinical assessment and medication. So these babies will have pain, so you want to give them analgesics. It's the intestines are involved, so you can give them some antibiotics, either prophylactic or if it's peritonitis, You obviously will go into theater, but also you cover them with some antibiotics. Give them IV fluids, boluses, and maintenance doses. And if you find any electrolyte imbalances, you want to correct that. Then basically on what you find in that patient, you'll just correct. These are just some of the things you can do. Now it's very dependent on the patient and what you find from their labs and all of that. Now in definitive, we have two things. We have operative and non-operative. Okay, we divide them into operative, non-operative. So we'll start with non-operative. So non-operative, you have pneumatic reduction and hydrostatic reduction. So for pneumatic reduction, this is when you use air, and it's the most common used. It's the first line in non-operative management. So you have assessed this child, you know you're not going to theater, you can start with non-operative, you will start with pneumatic reduction. So what you do is you use air, you push it through the rectum, and there are certain pressures that are used, maximum of about 80 in infants and about 110 to 120 in older children and adults. You don't want to perforate the bowel with that air. So you're going to push with those pressures, and you're going to monitor with fluoroscopy. So you'll be able to see air pass through, and you can see here the claw sign, right? So it will all obviously confirm that there's an intussusception. And then as you're pushing the air, it's kind of pushing this proximal bowel that has invaginated now back to where it came from. Okay, so you do that. The advantages is you can really control your pressures. There's higher reduction rates seen in this type of reduction. So if there's no pathological lead point, 75 to 90%. In some cases with pathological lead point, what I've seen is people like to do surgery because they can treat the lead point also, but some of them have tried to do, they've also done pneumatic reductions and seen about 60% of reduction in this. So it's quicker, it's cleaner, safer. They're exposed to radiation, but not as much. Yeah, basically those are the things. And then now the disadvantages of this is you will not be able to visualize a lead point in this. Remember, this is an X-ray. You're not seeing soft tissue that well. And another would be poor visualization of the intussusception and the reduction process. So the contrast, like we'll talk about hydrostatic reduction, will actually show you this reduction a bit better, and you'll even be able to visualize that intussusception much better. So sometimes what people do is after a pneumatic reduction, they just do a contrast enema to ensure that it has been reduced, or if it's not, that enema will also reduce it further. So this is now hydrostatic. So here they tend to use water, normal saline, or any water-soluble contrast. So you can now, you see how you can monitor even better. You can see that claw sign much better in this hydrostatic reduction. So you push in, you'll use a Foley's catheter, put it into the patient's rectum, and then now you're going to push the fluid that you're using. So you'll be able to see the claw sign, and then it will reduce your intussusception. So the rates for this without a pathological lead point, 73 to 91%, 50% if there's a lead point. So the advantage is non-invasive, it's a cheaper option, there's a shorter stay compared to surgical methods. So I want you guys to remember this rule of threes. So the first three in this rule of threes is you can do up to 3 separate reduction attempts. So you do your first reduction with either air or water. It maybe doesn't do it completely or it's failed, you can do a second one. If it fails, you can do a third one. Now, if you've done 3 attempts and it still isn't reducing, then you need to take the patient to theater. The second one is each of these attempts should last for about 3 minutes. So when you're pushing in the air or pushing in the water or whatever contrast or substance you're using, you need to do it for 3 minutes. Each attempt should last for 3 minutes with the same pressure, whatever pressure you're using, that's sustained pressure. Then the third one is mainly for now the hydrostatic reduction is the bag that's going to have the fluid you're using, the enema bag, should be elevated 3 feet above the table that the patient is on and ensure adequate pressure is being given. Okay, so 3 separate attempts, 3 minutes each attempt, and 3 feet above the fluoroscopy table or above the patient. Okay, that is for hydrostatic reduction. So There are contraindications to this non-operative management. We talked about if you suspect or you've seen gangrenous bowel, don't do none. You need to take them to theater. Any perforations, peritonitis, shock, total intestinal obstruction, you do not want to do operative management. So how do you know if it's successful? You'll be able to see. So when you look at it, as this passes, you'll see the fluid or the air pass through, go, and then now enter into the small bowel. So once you've entered, this fluid or air has entered in the small bowel, you can say that's a successful reduction. And even the child will now be symptom free. They'll be happy. Whatever mass is there would have gone. They're not in pain anymore. They're not crying. They're feeding well. The blood has stopped. They're not vomiting. The child is doing well clinically. Sometimes you'll also see flatus of feces pass. So you pushed in saline, you've pushed, then you'll just see the feces come out, or even baby will pass gas. So you know you've succeeded. So some of the complications, a few complications is recurrence. This intussusception can recur after non-operative management. So you need to observe this patient. You can have perforation, although rare, it can happen. And the most common site of perforation is actually the rectum. So while you're looking at where the intussusception is and monitoring how it's going, you need to also make sure that the rectum, the diameter is fine, because you don't want perforation to happen. Okay, so now we talk about, okay, sorry, this is operative, not non-operative. So when do we take them to theater? So you take them to theater when you've had a non-operative failure. So you've tried the 3 attempts or whatever, and the reduction hasn't happened. So you want to take them to theater. Again, those contraindications of the non-operative are indications for this operative one. So gangrene, perforation, peritonitis, shock, total intestinal obstruction. That's when you're going straight to surgical management. So what can you do in intra-op? So they prefer to do laparotomies more than laparoscopy. So in a laparotomy, what you can do is you can do manual reduction. So you have milking or squeezing of the distal bowel, and try not to pull the proximal. So if I could take us maybe to an image, just to show you what that means. So you can see this is the distal bowel, this is the proximal. So what you're doing is you're going to find the apex. Remember we said the apex is the most distal part of the intussusceptum. So you'll find that point, then you're going to squeeze from that area out towards the proximal end. So you're squeezing from here, kind of milking the intussusceptum out of this distal bowel. Try not to pull this proximal end, because you don't want it to, you might have some tears or ruptures or perforations happening as you pull. So the main thing is you milking it out, okay? Then what else can you do? You can also assess the viability of the bowel. You want to check if there's any necrosed tissue or gangrenous bowel, which you need to resect. So if you find any gangrenous bowel, you need to resect and then create an anastomosis now between the healthy bowel. You can also examine for any lead points and correct any that you're able to, like a cyst or a polyp, you can easily remove it from there. If you need to give time for the bowel to heal, you'd want to fashion a stoma, allow for the distal bowel or whatever bowel you want to heal while the stoma is doing its function, and then you can reverse the stoma once you're good, that you know that the intestines are fine, you can remove it. Yeah, so this is just some principles for the surgery. So ideally, you're just trying to reduce the intussusception, trying to remove any lead points you find, resecting any gangrenous bowel. Okay. So what are the complications of surgery? You can divide complications into immediate, early, and late. So immediate, you'll have just baby wakes up, they're going to be in pain immediately after the surgery because you've cut into them. So you want to cover them with analgesics. You can have bleeding, hemorrhage intra-op, or maybe even post. You can correct that when it happens. Early, you can have infections and you can have wound dehiscence, okay? So SSIs and all of that, or the wound isn't healing well. Late complications, any surgery that involves the abdomen, adhesions, you can never go wrong with saying adhesions is a complication. You can have recurrence of the disease, and then you can have stoma complications. So if you've put a stoma in this patient, you can have a look at what are the complications of having a stoma. Yeah, so those are some of the complications. So if it's okay with all of us, I'd just like to quickly go through a case discussion of a patient I'd actually clerked in the ward, and I thought it would be really nice to learn something from this history. So if you don't mind, we could quickly just put in answers into the chat so that we don't waste a lot of time, right? So let's begin. We have a 1 year old 3 month old female present from Eldoret presented with left abdominal swelling for the past 1 week. So what further history would you like to get from the mother? Maybe give like a minute, just everyone could just quickly put in their answers. Okay, current UTI, how's the stool? Okay, good. Onset of the swelling, irritability, good. Vomiting. Okay, there's been poor feeding. Yeah, another 20 seconds for people to put in anything else they think. Duration of swelling, fever, trauma, good. Relieving aggravating factors, okay. Frequency and quality of stool passed. All right, good, thank you. So this is the history I got from this mom. Sorry, it looks like this color of stool. All right, so this is the history I got. So the swelling was noticed suddenly and increased when the baby was crying or feeding. Irritable, intermittent crying, especially after feeding. There was reduced playing, refusal to feed 4 days before admission, and a history of not passing stool 3 days prior to admission. So there was constipation, and prior to that, there was no blood in stool. The stool was normal. There was a failure to thrive. The birth weight was 4.2 kgs, and the current weight, this is a 1-year-old child, was 6.4 kgs. There was no fever, no vomiting, no history of respiratory infections, no family history of similar symptoms. There have been 2 previous admissions for abdominal pain, vomiting, and it was treated with medications. The baby is also allergic to sulfur medications. ANC was unremarkable. Birth history, SVD, live female infant, 4.2 kgs, cried immediately, passed meconium on the first day, no complications, was discharged within 24 hours. Developmental milestones is still not able to stand or walk without support, and the immunization is up to date. So what examination would you do and which signs would you like to elicit? Maybe another 1 minute. You can put in your answers in the chat. Abdominal exam. General examination. Okay. DRE, the dance sign. Another 10 seconds. Anyone tenderness, any guarding? Okay, neuromuscular, skeleton, interesting. General exam, slow capri fill, slow skin pinch. All right. That's very interesting. Maybe the one who said neuromuscular or neuro and muscular exam, you could put why you wanted to do that examination. So my examination findings was a young female patient in fair general condition, no obvious resp distress, a heart rate of 158, resp rate of 55, a temp of 36.7, a MOC of 10.9, weight was 6.4 kgs. She had conjunctival and pulmonary pallor with no edema. Abdominal exam, which was asymmetric, moving with respiration, distended. There was an umbilical swelling increasing when the baby cried, reducible. On palpation, there was a positive dance sign. There was a mass in the left upper quadrant, which was firm, non-mobile, 6 by 6 and tender. No organomegaly, tympanic tympanic abdomen, no signs of ascites, and bowel sounds were present. A CVS exam revealed a pansystolic murmur. So now from that, what would your differentials be? And what investigations would you like to do? So another minute. Am I still audible? I don't know. No one is just okay. Okay. Labs. Ultrasound. Okay. Intussusception is a differential. Severe acute malnutrition, splenomegaly. Peritonitis, sepsis. Okay. Echo. Mesenteric cyst. Possible congenital heart defect. All right, good. So the investigations we had, we did a full blood count and the baby's HB was 4.1. They had normal WBCs and the platelets were fine. The UCs also were normal, BGA was normal. On ultrasound, there was a target sign and dilated large bowel loops. So an echo was ordered. From this now, what is your treatment plan? So what would you want to do in this patient? So a target sign was, okay, as other people are, let me just quickly go back. The target sign was seen in an ultrasound where you have altering hypo and hypoechoic bands. So you can see this is a hypoechoic band, then you have like a hyper, which is more white, then again another hypo. So it looks like a target. If you've ever played darts, or just Google a darts target, it looks something like that. It's also called the donut sign. So it's normally seen in an ultrasound. I hope that has answered your question. Good. So supportive blood transfusion, fluids, antibiotics, keep the patient MPO, decompress, supportive management, blood transfusion, fluids, cardio consult, GXM, pneumatic reduction. Okay, anything else? Okay, good. Pressure reduction, NG tube. All right, so what was done for this patient was we gave the patient 2 pints of blood. I also gave them analgesics, gave them was on IV fluids. I think before they went to theater, they were given about 4 bags of fluids. After we corrected the HB and saw that the baby was okay, we took the baby to theater. Sorry, I don't know what's happening. Oh. 1 second. Yes, so we took the baby to theater and the intra-op findings was a mesenteric cyst in the transverse colon, removed and sent for pathology. There was no intussusception seen in intra-op. No gangrenous bowel was found. So we just removed this, the cyst was removed and the baby's abdomen was closed. So what was left to be done was to do an echo and consult pediatrics for the severe acute malnutrition and suspected congenital heart disease. So in this patient, initially the differential of diagnosis of SAM, intussusception, and suspected congenital heart disease was made. There was also severe anemia, which is so now I told you, depending on the patient, your conservative management supportive will change, right? So in this patient, you'd give analgesics, you'd have to give the patient blood. Their electrolytes were fine, they didn't have any kidney issues, so we didn't have to correct anything in the electrolytes. I think they opted to go for surgery because the anemia was very suspicious. So they were thinking there could be an underlying pathology relating to the intussusception. So they chose not to do the non-operative. They went to theater to figure out what's happening. Yeah, so that's what they saw. So there were 2 reasons for this. Either number 1 one learning point from here is this could have been a mesenteric cyst, which was the pathological lead point. There was an intussusception, but because the patient was in the ward for 5 days, sometimes these things can resolve on their own. Like you can have an intussusception and then it resolves on its own. So either that happened, or number two, sometimes you need to keep your mind open. Your patient might be presenting with signs of intussusception symptoms. Even your findings may, like ultrasound findings, look like it was intussusception, but you go in and it's something different. So keep your mind open to differentials. The mesenteric cyst was one of them, which is what they found. So that's what they're thinking. Like they presented like an intussusception, but ended up being a mesenteric cyst. The mesenteric cyst could have pulled bowel towards the left side, and that's why the right was empty. Yeah, so now what would be left to do in this patient would be to deal with the SAM and even figure out if there's any congenital heart disease happening. So by the time I was leaving this patient, the echo had not been done, so I was not able to find the findings. So yeah, that's just what I wanted to show you from this presentation on just keep your mind open, and every patient, your management will differ in relation to the patient that you have. Yes, thank you so much for listening. If you have any questions, feel free to ask. Okay, how much fluid in hydrostatic management do we instill? Abdominal radiograph, the opaqueness when instilling fluid. Is it clear fluid impregnated with radioactive material? So for the second question, the fluid sometimes just water. It's actually just water or normal saline. You'll be able to see it like that on, maybe that image had some radioactive material. I found it on the internet. But ideally not, they don't use radioactive material, just normal saline is what they use. Fluid, I've seen different sources. They say about 2 liters, 3 liters. It varies. So about that much, 1 to 2 liters of fluid. So you're putting that in for 3 minutes in each attempt. Yes. So I think I'll hand over to Melanie. I don't know, should I answer the questions now before you do the Kahoot session?
Yes, you can answer before we do the Kahoot session.
Okay. Are all patients taken through non-operative since it has a... No. So not all patients are taken through. Like I said, if you're suspecting gangrene, peritonitis, shock, all of those things, you don't want to do non-operative. Another thing is if you've seen a lead point, if you've investigated your CT scan or your ultrasound is showing you a lead point, you want to go into theater, because you might correct the intussusception, but you've not removed the underlying cause, right? So you want to get rid of that lead point. Like you want to remove the cyst or remove the polyp, or if it's in adults, remove the tumor, those kind of things. So not all patients will be taken through non-operative as the first. But young children, no complications, doesn't seem like there's a lead point, you can start with non-operative management. Yeah, hope that made sense.
Thank you so much, Samara. What a beautiful presentation. So as maybe if there are other questions, you can answer them while people join the Kahoot session.
All right, yeah, you can just post comments, my questions.
If you guys have any more questions while you join the Kahoot session, you can ask them now.
Just as you guys join, another learning point from the history taken was don't, just because it was a presentation from the abdominal abdominal history, we tend to really focus on examining the abdomen. But because a registrar actually listened to the heart and had the failure to thrive in mind, the systolic murmur was being picked up, and so they can go further for management of that. So always investigate the patient as a whole or examine. Yeah.
Okay, so if this session was helpful to you and you would like to give back to XYZZ, we currently have a research project going on, and we would like you guys to fill out the form that I sent in the chat. Since there's 28 of us here, I expect 28 new forms. So please just take time and fill this out. Okay, I think we'll wait for like one more minute, and then we can start the Kahoot. Okay, here we go. Which of the following best describes intussusception? BCI is on top. Um, which of the following is the most common cause of intussusception? So the correct answer is idiopathic etiology. I see 7 got it correct. Okay. The most common type of intussusception is ileocolic. Yeah, I feel like that one we did well. Which one is the triad seen in intussusception? Abdominal pain, a mass, and red currant. Jellies too. Okay, I see you, PS. AO is still taking the lead. Also, the faster you answer these questions, the more points you get. Okay, which sign would suggest intussusception in an 8-year-old with colicky, abdominal pain, and blood in stool? The correct answer is empty right iliac fossa with abdominal mass. I feel like we're doing well. Okay. A baby presents with intermittent irritability, left abdominal mass, bloody stool, and positive Down sign. What priority investigation would you do? No, 10 out of 10. Okay. Which is not a radiological finding of intussusception? Coffee bean sign. Hmm. Which of the following is true about intussusception? Okay, this one was a bit tricky. Patients aged 5 months to 2 years rarely have a lead point. It's the correct answer. Wow. Good job, AO. Which of the following is a complication of intussusception? All of the above. Margin to me. Okay. A baby presents with intermittent abdominal pain, postprandial vomiting, and blood in stool with target sign on ultrasound. What's the first line treatment? Okay, pneumatic reduction, correct. That was probably our fastest round ever. Let's see who won. In third place, we have Majim Tunguni. Then we have DCI. And in first place, we have AO. I wish you guys didn't use like pseudonyms. I wish this was the actual names. Okay, congratulations, AO. Nice. Okay, I guess that was good. It was a good quiz. Okay. Well, thank you guys for attending this session. Please fill out the form, the survey that's in the chat. And if you could send this out to your friends, we would appreciate it. That being said, thank you for attending, and yes, and follow XYZ Med. And have a good day. See you next week.